Greetings and salutations, and welcome to Dialogue with Darinda, Volume 22, here with our President and CEO, Darinda J. How have you been?
Doing great. This cold weather. We feel like
about to get colder.
We feel like we've been transplanted to the North United States.
We'll get through it, though. We've been through everything so far. We'll get through this. Yes. So let's dive right into this. Some news around the vaccine, BAMLAM coming down the pipe.
Yes, you know, since last time I talked, we were not selected. Probably many of you saw this on TV and some news sectors where we were not one of the hospitals chosen for the high distribution hospital system. So some hospitals were chosen as a pilot this month to be given a pool of doses. So there's 4 hospitals in our Region A. So they were given 5,000 doses guaranteed to split up and give a lot to their communities. I have been campaigning to get us into that for March because it's a good predictable way to get vaccine. And we are doing a good job, but in comparison, those counties that are in that, Henry and Pettis are both at almost 12% vaccinated, and we're only a little under 6%. So even though we've given 3,800 doses, we haven't gotten to where we need to be. So, but despite that, we are getting doses. We have a team of people working really hard. Every one of our clinics has went very well. So we've been as soon as we get the vaccine, we've been vaccinating people. So this week we were awarded 300 from the state, and so we have a clinic for Friday that so pretty much we're always going to plan them for Fridays because we know on Mondays or Tuesdays if we're going to get it, and then that gives us time to call people and schedule. So that's how we're doing it now. So we're having a clinic Friday. Next week we're having a clinic on Tuesday at UCM because Bothwell had a lot from their high distribution, and so they are going to let me know Saturday afternoon how much they're going to transfer to us, which we think is going to be between 250 and 500.
It's good to see the communication. And
very well, yes. And then they promised us 500 doses of their shipment on the 22nd, so we planned a clinic with that too. So not only are we starting some of our second dose clinics, but we're still getting vaccine to do the first dose clinics, but we want as much as we can get because we want to get as many vaccinated people as we can. And the state's goal is that when you get it, you give it within 5 to 7 days. So it is, you know, we're not holding on to any, we're giving everything we have. So it's going really well though. I'm getting so much positive feedback from the public about the clinics. And so I'm really proud of the team that have been really driving that.
Have you seen as time goes by that maybe some of the resistors are starting to maybe come around, or have you heard about that throughout the community, or has there even been any kind of goal set around that about how many we want to get vaxxed? No, we don't have any goals set as a county, but because we have only given 3,800, and that's between the health department and us, I don't think we've gotten past the people who really wanted it. So, you know, the first 2,100 people that signed up on our list the first day, we're there.
They all wanted it. And so we're still on the tail end of that first 2,100 people. And so I don't think we have gotten into the next sector of people that were waiting to see how everybody responded. And
then understand the BAMLAM.
Yeah, so BAMLAM is the medication.
That's almost like an infusion, correct?
It is. It is an infusion,
okay.
And it is biological, synthetic, similar antibodies that they are giving to COVID-positive patients who don't need inpatient. So they're COVID positive. They have all the risk factors of heart disease or diabetes or one of those things, and they don't need admission yet. So they give them this infusion so that they hopefully will not progress. So they'll create antibodies to COVID and keep them from being inpatient. Now, we've given 37 doses that we were awarded by the state, and honestly, our admissions are down for COVID. And that is the same story at every other hospital. And we are crediting that a lot of this is the BAMLAM response, and that we are helping people stay healthier and not get sick enough to be an inpatient. So we gave our last dose of our initial 37 last Friday, I believe. And I reached out to the CEO of Bothwell in Sedalia, and she actually, they had a lot there. They were given more doses for whatever reason, or had 2 different vendors. And so they actually transferred 37 doses to us. Or we had 17, I'm so sorry. We had 17 in the beginning. We gave our 17. They gave us 37 doses more. So we have that here, and now we're able to give it again. And so we have a good process for that. People here that are trained to give the medication and monitor them. for the hour afterwards, and the primary care physicians know how to identify those patients that qualify and how to call over and get them scheduled for it. So
when I
that's
first
really
saw
great.
this, when I first saw this going on, I thought, oh, we've got some overflow infusions today. And then I found out that it's actually
It's very specific. Yep.
yes, what's going on there.
Mhm.
And throughout all of this process, we've had sort of a survey result come back to the hospital that had some really good outcomes.
Absolutely. I presented this to the board at the January board meeting. And so, as you guys know, last October, we all took our employee engagement survey. I do not take it. I'm going to give myself perfect. But we did that in October. And so we got those results sometime around New Year's. And so we haven't got those all distributed yet because you do have to be careful. You don't want, if a department's small. So there is some science to it. You don't want to give them out and they only have 3 people and they might be able to figure out who said it.
Uh-oh.
So we have to make sure that they're grouped together so people can't identify. But when you look at the whole group, which is what I do, and I think we should all be proud, the whole group, every single question went up. Every single question was in the green. So we didn't have any reds this time. So it doesn't mean we don't have things to work on, because what we're going to do, so you can be expecting your leader to be showing you those results as we get those out and make some plans and read them. But it really is about why is this so high? This looks like a strength of us, and so I want people to tell their leader why that was a strength, because we need to know that something we're doing, if that's really affecting that works. And so you can strengthen strengths, so instead of looking at, oh, we're terrible at XYZ, here's all the red ones we need to work on, you can still do that for our lower scores, but we can also strengthen those things that are already high, because they are obviously noticeable, or people wouldn't be scoring them high. So sometimes, though, I think in leadership, we don't really know why you clicked that. We're like, what am I doing that made that high? And so I think people need to say, well, I think you do, this dialogue with Darinda is a good communication tool or something like that. So we need to know why some of those scores are high so that we can continue to do that.
In the survey world, I get asked with the patient satisfaction surveys sometimes, well, what do we have to do to get that percentage to go up? And I said, well, you generally got to take that 5 and turn it into a 7, or that 7 on the 1 to 10 rating and turn it into a 9, and then that'll pull that percentage.
Right.
So it sounds like that we've been able to do that over time since the last survey.
Since the last survey, what I would say, if you look at that way, everything was above a 3. The average score for every single question
on a Likert scale, like
1 through 5,
1 through 5,
everything was above 3.5. Everything. And so that might not be true. There might have been a few between 3 and 3.5, but everything was above 3.
Mm-hmm.
There was nothing average below 3 on the needs improvement or horrible. So we have moved that a little bit because we had some down that way, a couple. So we have been working on some of that stuff, and some of it just is, we've worked so well together this year. Mm-hmm. The more a team work as one, we feel people are going to feel better about the organization. And so I think that has made a difference, but trying to stick together and keep everybody safe, I think may have pulled us together too this year.
And again, kind of segueing on, and I feel like we're going through the pillars today because we're going to talk a little bit about some growth that's going on now too.
Yeah.
So although we're busy, we're in a pandemic, we're still doing well, getting good feedback, opening new service lines, the interventional pain clinic, and I understand there's kind of more on the horizon.
There is. So non-interventional pain clinic opened
I always
this week.
get that wrong.
So it's part of our comprehensive pain strategy, and so we did hire a nurse practitioner that has experience in a pain clinic. And so the idea of that is so that physicians, primary care physicians that have patients that have medication, narcotic needs, they can send them to her. She can run the traps. She can send them to PT. She can make sure that we're doing the right thing, that they're on the right dose, that they're weaned appropriately, those kinds of things. And so it's really to assist the patient find better pain control, but it's also to assist the primary care doctor so that someone is taking a little bit more time to try and troubleshoot that pain.
So is that like a holistic kind of
It's much more
approach?
holistic.
Okay.
That doesn't mean she won't refer to some, like
Sure.
if it's back pain, she may, end up after XYZ, she may refer over to the interventional pain center where Dr. Doss is.
Mm-hmm.
There's a lot of steps in the algorithm that she'll be assessing. And so right now she has got a collaborating physician here in this system. Dr. Thiermalai is doing that for us for 3 months. And then we're transitioning to a pain doctor from outside that's going to collaborate with her, and he'll do more telemedicine if he sees patients. So So more to come on that, but that clinic is open and it's operating on the north end of Bone and Joint. So we had some extra space there, and it's nice space, so that's where she'll be. We have some other fun things coming. On the horizon, May 1st-ish, we're planning an endocrine clinic. We have an endocrinologist that is going to be doing telemedicine. We're finalizing that contract now, which is very, very needed. CCTA, which is the cardiac CT angiography. That is something that I'm so excited about. Dr. Almeida, we start this, I think, in a week with the test patients, but Dr. Almeida is one of the HCA cardiologists over at the HCA multi-specialty building, and he has advanced training in diagnostic imaging for cardiac. So what this does is if patients have certain risk factors, you can do this CT of their heart, and there's a special software that, and he can take away all the structures so he can see, and there's some things they have to do. It's not as easy as just going to get a CT. But for these patients...
CT on steroids, basically.
It is, CT on steroids. So that he can see actually all the arteries in your heart. He can see the blockages. There's even ways to see if the flow is affected, because sometimes you can have a blockage and the flow wouldn't be affected, or sometimes you can have a small blockage and the flow is very affected. So traditionally, the only way you've been able to get that information is by doing a catheterization, which can be dangerous. They're routine, but they're expensive. They can be dangerous. There are risks involved with sticking something up your groin into your arteries. You can, you know, break through the wall, those kinds of things. Doesn't come without danger. And sometimes they go in there to look because you have all the symptoms and you have all the things, but they can't see what's in there, so they go in to look. And sometimes those patients, it's a clean cath. They don't need a stent. A lot of times they don't need a stent. They don't need open heart, and they go about their day. This CT would replace that. So they could look at the heart, see, oh my gosh, you just have one little bitty blockage and the flow is not really affected, so we're just going to watch that.
So it's non-invasive.
It's non-invasive, yeah. They give you medication to slow your heart so that they can really see it when you do the CT, but it's non-invasive, it's just a CT. And then if they do that though, and they see, okay, that you have 4 really big blockages, we can't tell on the flow on this one, or 2 blockages, we need to do a cath to put a stent in. You know, so they can preempt. So you might move to a catheterization, which is much more recovery, expense, all those things, danger. But that wouldn't be your first step. And so this is a tool that for a community hospital like ourselves, like I love cardiac. My experience as a nurse, I had a lot of cardiac experience, and so this is my thing. Like I just love this because a lot of people have heart disease. And what's been our place in this community? We haven't really known. We don't have a cath lab.
Send out.
You know, we don't really need to have a cath lab. This is our place. You know, help people identify early, be able to screen early so that they're not having heart attacks and going for the stent or having unnecessary catheterizations, which drives up the cost of healthcare and danger. Again, I mean, I literally have seen patients, take care of patients who have had bad outcomes from just having a cath. So it isn't without risk. And so you can imagine that some, you know, businesses, it's lucrative to do catheterizations, so they don't necessarily want to push the CTA. But for us, we don't have a cath lab. This is a perfect thing. I think this is how we find our place in the community, as we help people get to that heart disease quicker and with a thorough test. So I'm so excited about it. I can't tell you how excited I am about it.
Is this a new piece of equipment or something we use with our existing?
It's our existing CT, but we did have to add a cardiac package. So It's a little bit of cost, but not much. Sure. They're going to be doing the pre and post recovery of these patients in endoscopy. Susan Thurston, our stress test nurse, really is leading. You know, she's really the one responsible for these types of patients. So I think we're going to do them only on Wednesdays for now. And we're not going to do them like if someone comes in the ER with chest pain, we're not going to say send them for a CCTA. No, but they could be scheduled outpatient for a CCTA. But any doctor can order this, and then Dr. Almeida will read it. And so we're billing the technical and the CT, so you'll get that bill for the CT, but then Dr. Almeida will be billing for his services. So if you have one done, you will get a bill for that that professional service piece from HCA Dr. Almeida. So, but any doctor can order it. So if Dr. Glover thinks his patient needs one, he can order it, they'll have it done, Dr. Almeida will read it, and they'll have the results and know where to go with their patient from there.
And when's the go live on that?
I think they start test patients the 17th.
So very soon.
Yeah. So.
And then one more thing I understand on the horizon, moving up toward the I-70 corridor.
Yeah.
There at Sweet Springs. What's going on there?
This is interesting. So Sweet Springs had the I-70 community hospital, and that hospital did close. It changed hands a couple times. It closed. So that community, actually, I don't know if everybody knows this, that city funded that hospital originally, like back in 2005. They, as a city, opened that hospital because they felt like they needed it. Well, now here we go, all these years later, that the hospital's closed. So that community still feels like, gosh, we're right here on I-70. There's all these wrecks. Like, we don't have any doctors here. There's no hospital. Like, they feel like they have to drive to seek health care. And so they reached out to us, actually, and about having a primary care clinic there with a telemedicine kiosk, really. And so we have explored that, and we start, I think we go live the 22nd of February. So there will be a laptop kiosk site there in this pharmacy marketplace. I wish I knew the name. You'll see some marketing coming out. And so the patient, this visit will be ran by Concordia, because that's the most natural place. It's only like 10 or 15 miles away. So those patients can establish care with Concordia, and then they can see their doctor from that kiosk. So they can schedule appointments from the kiosk, with Concordia at the kiosk, so they don't have to drive. But not everybody has, I guess, good enough internet, so they can't do the virtual visits from home. So this just kind of eliminates the virtual visit at home thing. It just lets them drive up to the local pharmacy and do it from there.
So they probably have the proper bandwidth, everything needed to connect.
We rented the little space to put that, very cheap. There was minimal cost involved with trying this. We did increase the bandwidth to make sure that our equipment would work correctly. So there was a little bit of cost there, but it really is a low cost thing that could really help a community, and also shows our involvement and our commitment to helping people. And we need to grow Concordia's clinic. So it's a win-win, I think.
So is that manned by someone from us, or is that?
No, the pharmacy will help people get set up.
Okay.
But they'll schedule it, and I have not been involved in these discussions, so I don't know everything. But they will somehow contact Concordia with a number. They'll set up a time. I mean, it's not like you just walk up and push the button like I want the doctor. There's a time.
Sure.
And so then they set up this virtual visit from this kiosk, and then the doctor and the patient set together. That pharmacy, they'll make sure people get set to the right place. If they're like, I'm here for my doctor visit, they'll say it's right there, But we don't need anybody in the room.
Okay.
So.
I understand.
Yeah.
Well, I think that was all of our checklists.
Pretty exciting stuff. That stuff is exciting. Like, I love to do that stuff because it brings new things to people.
Could gain new patients.
Could be offering something so people don't have to drive.
Expand that footprint.
So like endocrine here in this community, we don't have endocrine anymore. St. Luke's moved theirs. That's a really big, if you ask any physician what kind of specialty we need here in town, they'll say endocrine. So having an endocrine option is amazing. And it will be our clinic. So it's not like we will have St. Luke's scheduling patients from Overland Park at our clinic. Like it'll be our clinic. And so we shouldn't be gathering patients from far away. I don't care. I mean, we'll care for them, but it should be our resource. It likewise will be our revenue gain for running that clinic. So.
All right. Did we hit it all today?
Oh, I think so.
There's quite a bit to
Lots
talk
of
about,
stuff.
but it was good stuff.
Yeah.
Lots of things on the horizon, which is good and exciting. And as we get that percentage of people vaccinated and the percentage of test positive keeps going in the right direction, things will get better.
Yeah.
And someday it'll get warm again.
That would be nice.
Past about Tuesday, I think. Well, thank you so much for joining us once again. This has been Dialogue with Darinda. I'm patient advocate Sam Stecklin. We'll see you next time.